Let's start available. Getting ready. Mute ஒண்ணுமே வரல. அதுதான் வரவே இல்லை.
Good afternoon, ma'am. Ma'am, are you available? We can start from your side, ma'am.
Okay, ma'am. Begin the session, ma'am. Everyone, ma'am, am I audible, ma'am?
Yes, ma'am. Yes, you are audible.
The 37th edition of the Chengai Pediatric Meet organized by IAP Chengalpattu. Three interesting pediatric cases from Sri Bala Medical College, Chetty Hospital Research Institute, and Sri Satyasai Medical College academic discussion. And extend my warm welcome to all the faculties, postgraduates, and the moderators. And I wish to the presenters here. And without further delay, let's move on to the academic session. Now I invite first presenter, Dr. Priyanka from Sri Balaji Medical College to present on the topic early bleeding, unexpected diagnosis, a prepubertal puzzle.
Good afternoon, everyone. I'm Priyanka, second year pediatric PG from Sri Balaji Medical College and Hospital. My presentation title is Early Bleeding, Unexpected Diagnosis, a Prepubertal Puzzle. The 8 years old prepubertal girl, previously healthy child, presented with the complaints of bleeding per vagina for 3 days, burning micturition for 3 days, genital itching. There was no history suggesting fever, foul discharge, foreign body incision, drug intake, or similar past episode. And an important clinical principle is prepubertal vaginal bleeding is always abnormal and requires systemic evaluation. One important differential diagnosis of prepubertal vaginal bleeding, which we should never miss in our day-to-day practice, is sexual abuse. Now the question is it a vaginal bleeding or bleeding from a urinary tract mimicking vaginal origin? Examination was done under aseptic precautions. Consent was obtained from the mother and the patient. Stables were vital, no PLR, fever, no external injury, no secondary sexual character, TANS stage 1. On local examination, a exophytic lesion 1 to 2 centimeter, friable mass which bleeds on touch and tenderness was present. Now, the differential diagnosis, which is the most possible causes of prepubertal bleeding, is infection, trauma, hormonal, foreign body, and sexual cause. In this case, it was less likely to be infection because the child had no fever, purulent discharge, diarrhea, so infection was excluded. And there was no history of trauma, bruising, tear. So trauma was also excluded. In case of foreign body, the child may have chronic discharge. On examination, object might be visualized. But here, the examination finding was negative, hence foreign body was excluded. Previous puberty was excluded was the child remained Tanner stage 1 and there was no breast development and pubic hair. So in this case, only dysuria was present with a periurethral lesion and contact bleeding suggestive of structural or neoplastic lesion, which requires a focused urogenital evaluation. First, the laboratory investigation in which the hemoglobin was normal, total leukocyte counts was normal, platelet was adequate, peripheral smear was normal, RFT, LFT, which was within the normal limit, and coagulation profile, which was normal, and urine culture, no growth was seen. Hence, the laboratory findings suggest that there was no infection or no coagulation abnormality. Assumed a hypoechoic vascular lesion arising near the vaginal wall was seen. In CCT, enhancing periurethral lesion of size 1.5 centimeter, 1 centimeter cross 1.4 centimeter, the imaging differential diagnosis suggests rhabdomyosarcoma hemangioma. An MRI shows a well-defined lesion 10 cross 15.3 cross 14.7 mm extending periurethral into vagina, localized, and it is which shows well-defined, mildly enhancing soft tissue lesion in the periurethral perineal region. The image suggests the mass the diagnosis was uncertain. Endoscopic done, which is the gold standard. Cystoscopy and gendroscopy was done, that finding urethra opening through the periurethral lesion, bladder mucosa was normal, vaginal cavity was normal, lesion confined to urethral mucosa. Targeted biopsy was taken, which the urethral lining epithelium with the cystically dilated Von Brunn nest in the lamina propria with the vascular channel. So the final diagnosis was cystitis cystica with a vascular malformation. This is the histopathological image, which shows that in the bladder mucosa shows a cystically dilated Von Brunn nest cells in the lamina propria, consistent with cystitis cystica, and the underlying stroma reveals a irregular vascular channel filled with RBC, suggestive of vascular malformation. Why this case has created a diagnostic confusion? This condition is usually seen in adults and it is very rare in children and of prevalence of less than 1% and with extremely rare presentation simultaneous vaginal bleeding. Radiologically, it mimicked a rhabdomyosarcoma, urethral tumor, hemangioma. Only histopathology could confirm the diagnosis. The diagnosis confirmed benign reactive lesion. There were no radical surgery was required, conservatively managed with antibiotic, anti-inflammatory care, hydration, and observation. The outcome, bleeding resolved, child was asymptomatic, excellent prognosis was seen. So the final learning algorithm, prepubertal bleeding means we shouldn't assume as a gynecological cause. Always we have to examine the urethral lesion. Sexual abuse must be actively considered and excluded, given a significant prevalence, approximately 1 in 5 children in India. Imaging may mimic malignancy. Endoscopic and biopsy is the diagnostic key. We have to consider the rare benign condition like cystitis cystica. The discussion, cystitis cystica is a benign proliferative lesion of a bladder urothelium due to the chronic irritation. Vascular malformation is a congenital abnormality of blood vessels, which is very rare. Cystitis cystica can rarely coexist with vascular malformation. There is an increased risk of hematuria and bladder dysfunction. Epidemiology, cystitis cystica is most commonly seen in adult. Pediatric cases are very uncommon. And vascular malformation is very rare in urinary tract and are often present in childhood. The risk factors are chronic UTI, bladder trauma, obstruction, and catheterization. Pathophysiology, chronic irritation leads to the proliferation of cells, which leads to formation of cystic nest in the lamina propria. In cystitis cystica, if it is asymptomatic and incidental finding, conservative management, hydration, and we have to observe. If it is symptomatic such as hematuria, pain, dysuria is there, we have to treat the underlying causes like UTI, obstruction, and follow up urine analysis and USG. We have to treat the infection. In case of recurrent or severe cystitis, the recurrence rate is about 44%. Endoscopic resection or transurethral resection, we have to remove the cystic lesion. It is indicated if there is bleeding, pain, or obstruction is seen. For vascular malformation, if it is minor stable, no intervention, only we have to follow. If it is symptomatic bleeding, endoscopic risk of vascular malformation, laser ablation, partial cystectomy if extensive. The follow-up and prognosis are generally benign. It is generally benign condition. Recurrence possible if the underlying causes persist. We have to monitor for hematuria, bladder dysfunction. Highlighting the unusual nature of the case. These are my references. I'd like to thank Dr. Sundari ma'am, HOD and Professor of Department of Pediatrics, Dr. Ramya ma'am, Dr. Vijay Lakshmi ma'am, and Dr. Sridivya ma'am. I sincerely thank the Department of Obstetric and Gynecology, Sri Balaji College and Hospital for the valuable support guidance. And I also extend my Department of Pediatrics, Radiology and Pathology, Institute of Child Health and Hospital for children for the guidance and assistance in presentation. Thank you.
Thank you, Dr. Priyanka. That was an excellent presentation. Now I invite Dr. Sridivya to add her expert comments.
A very good afternoon to everyone. I thank Dr. Sundari ma'am for the opportunity to present this child. Only one thing that I would like to stress is clinical examination is of utmost importance. Parents will come with history of bleeding per vagina. It is our duty to find out the source of it. So because we found it's periurethral, so that's, and after ruling out sexual abuse, imaging guided us in ruling out malignancy because there was no bone erosion or regional lymphadenopathy. And HP is gold standard in diagnosing. So there's a very unrecognized entity in children. So we wanted to put forth this case so that we are aware of such a underrecognized entity, which it's a usually active lesion as a result of chronic irritation. Cause of irritation in this child, however, child improved well with management. And HP guided us in the final diagnosis. We are happy to take any questions.
What was the cause of irritation in this child?
So there was no obvious cause of irritation, sir. Patient actually came with dysuria and bleeding, sir, for the past 2 to 3 days. There was no history of worm infestation or any other urinary symptom. Labs also didn't reveal any infections or vulvovaginitis, sir. And there was no history of sexual abuse or trauma, past catheterization or any others. So we don't know, but the main cornerstone of management is to treat the underlying irritation, because if we don't do that, we are going to have recurrence. But in this child, we didn't have a definite reason for that irritation as yet.
You didn't get anything on culture? Urine culture?
Cultures were sterile, sir. No. Urine culture was sterile, sir. Urine microscopy and cultures were normal, sir. Even local examination was fine. There was no evidence of vulvovaginitis also. Actually, initially we suspected sexual abuse because that is more common in our setup. So mother clearly had any history. Even child was old enough to give history. So there was no history of abuse or infections.
I would like to know that there is cystitis cystica with hemangioma. So is there any role of steroids to prevent the recurrence of this? Since the risk for recurrence is almost 40%.
There are no clear-cut evidence or data suggesting steroids as a part of management. Any other questions? Can we move on to the next presentation?
Like, so if there is any hematuria or is the bleeding for vagina, is it regularly happening or cyclical? What kind of bleeding for vagina does the child does have?
Voice was not clear, ma'am. It was breaking. Can you repeat?
Hello, ma'am, am I audible? Ma'am, actually,
ma'am.
Sorry to say that. Ma'am, I just wanted to know if the bleeding by vagina, is it like cyclical or every day the child had, or is it like what if while urinating, something like that?
Actually the mother brought the child. The child had pads in her underwear, ma'am. It was like a menstrual bleeding, continuously bleeding. It was not like urinating. The child was brought with a sanitary pad in her innerwear. That is how they brought the child, and it was continuously bleeding throughout the day. So mother said they were changing nearly 2 pads per day.
Okay,
So it
this
was a
was,
continuous bleeding.
okay, this was there only for the past 9 days. Okay.
It was a continuous bleeding.
Now, what kind of treatment was given? Further, how did the child be managed?
As of now, pediatric surgeon suggested it's only conservative, ma'am. After the biopsy, child didn't have any further bleeding, so child is currently on follow-up, ma'am. So far, no recurrence. Child is doing well. So now we will move on to the next presentation. I invite Dr. Arjun Raj from Chettinad Hospital Research Institute to present on when the Dr. Arjun Raj, can you start? Yes, doctor. Purnima. Sorry, invite not in the case.
The screen is visible, ma'am. Good afternoon. Case when the lymph nodes tell a different story, a challenging case. A 10-year-old male child was brought by his parents with presenting complaints of fever for 4 days, with complaint of pain and swelling in the left neck for 4 days, because of vomiting for 1 day. History of present illness. Child was apparently normal 4 days back, after which he developed left side neck swelling associated with pain and difficulty in neck movements, which was gradual in onset, non-radiating, aggravated on the neck movements. History of fever, high grade, maximum recorded temperature was 104, relieved on medications associated with chills and rigors. History of throat pain for 4 days. History of difficulty in swallowing for 4 days. History of reduced oral intake was present. History of vomiting for 1 day, 4 to 5 episodes per day. Vomitus containing food particles, not blood or bile stained. No history of cough, cold, ear pain or ear discharge, no history of rash, no history of loose stools or abdominal pain, no history of burning, micturition or reduced urine output, no history of joint pain and joint swelling, no history of weight loss and night sweats was present. On day of illness 2, the child was brought to Chettinad. UST neck done showed matted lymph nodes of 5.1 into 2.2 centimeters in the left cervical region, and child was started on amoxiclav 4. And 4 doses were taken. There was no significant past history and no history of previous hospitalization. Antenatal and natal histories was uneventful in this child. With the developmental history, developmental milestone attained appropriate for age, studying 6th standard with a good scholastic performance. Family history, he was the firstborn of non-consanguineous marriage with no history of TB, asthma, and cardiac disorders in the family. Immunized up to 5 years of age, and according to national immunization schedule, and belonging to upper middle class of modified Kupusami scale. According to anthropometry, the child was overweight. General examination on admission, child was alert, active, febrile, 103 degree Fahrenheit, no pallor, icterus, cyanosis, or clubbing. Bilateral multiple cervical lymph nodes were palpable in the jugular area, largest measuring in the left side of 2 × 2 centimeters, tender, firm in consistency. Vitals, temperature was 103, heart rate was 122, with other vitals were stable. Head to toe examination, no facial dysmorphism. Ears, eyes, mouth were normal, with throat having posterior pharyngeal wall congestion. Skin, BCG scar was present, no scar. Limbs, no edema or erythema. Spine and cranium was normal. Genitalia is a male phenotype. Systemic examination, shape of the abdomen was flat with all quadrants moving equally with respiration. Skin appears normal with no scars and sinuses. The umbilicus was inverted central, no visible pulsations of peristalsis. On palpation, abdomen was soft with the liver palpable 3 centimeter below the right costal margin in the mid-clavicular line, non-tender, smooth in surface, firm in consistency with a liver span of 11 centimeters, no shifting dullness, and bowel sounds was heard. Other systemic examination was normal. Differential diagnosis we considered were cervical lymphadenitis, which is acute bacterial pharyngitis, EBV or TB, and tropical infections like dengue, scrub, enteric, and malaria. This child was admitted with the above mentioned complaints and investigations were done. Child was initially started on IV antibiotics, amoxiclav, followed by, which was escalated to piperacillin azobactam. Repeat USG neck which showed multiple enlarged left cervical lymph nodes, largest measuring 2.9 to 1.3 centimeters, which was mated lymph nodes with preserved hilum, no evidence of abscess or necrosis, consistent with cervical lymphadenitis. And USG abdomen showed hepatomegaly. Since the child had persistent fever spikes, the antibiotics were again escalated to clindamycin metronidazole. To rule out parapharyngeal retropharyngeal abscess, CT neck was done, which was normal. Investigations done on day 1, total count was 7,700 with the neutrophilic predominance and a platelet of 2.29. And day 3, it was 11,200 with neutrophilic predominance and the platelet was 1.52. And the peripheral smear showed normocytic normochromic with a relative neutrophilia. So day 1, CRP was 108 milligram per liter and ESR was 29 millimeter per hour and ASO was non-reactive. And day 3, CRP was again elevated of 173 and procalcitonin was 22.93. LFT parameters done showed a cholestatic picture with elevated liver enzymes. And urine routine done showed albumin plus, bile salts and bile pigments was plus, WBCs was 2 to 3, and blood culture, urine culture, and throat swab showed no growth. Other infective causes were ruled out, like dengue, NS1, IgM, ELISA was negative, scrub, lepto, and smear for MP and MF was negative. Viral capsid antigen for EBV and Paul Bunnell was negative. Viral panel was negative, and serology was also negative. And since in view of cervical lymphadenitis and persistent fever spikes, TB was suspected. MANTO was done, which was negative. Chest X-ray was normal. Sputum AFP and gene expert was negative. On day 5 of hospitalization, child developed a strawberry tongue and bilateral conjunctivitis and gradually started to develop pedal edema. In view of persistent fever spikes, strawberry tongue, cervical lymphadenitis, multi-system involvement with rising inflammatory markers, no other obvious microbial inflammation, atypical Kawasaki and MISC was suspected. Echo was done, which was normal, and antibiotics were continued, and plan was start to on IVIG if symptoms persist. So this is a picture showing bilateral conjunctivitis with cracking of the lips and strawberry tongue. Investigations done on day 5 and day 7. Day 5, it showed leukocytosis with 31,600 with neutrophilic predominance and thrombocytopenia. And day 7, again 36,300 with neutrophilic predominance and 1.18. On day 6, again, the CRP was 149 gram per liter, ESR was 34 mm, procalcitonin was elevated, and ferritin was also elevated 744. Coagulation profile was also elevated. LDH was elevated with fibrinogen was also elevated, which was 615. Peripheral smear showed normocytic normochromic fracture with the relative neutrophilia, neutrophilic leukocytosis with thrombocytopenia. So comparing the present case findings with the Kawasaki diagnostic criteria, the classical Kawasaki fever for more than equal to 5 days. Actually, this child had fever for 10 days. 4 out of 5 clinical features. This child had bilateral conjunctivitis, developed strawberry tongue after admission, and edema was present. Laboratory testings, there was elevated inflammatory markers. CRP was 108, ESR was 34. with anemia for age, which was 10.6, and platelet was 1.18 on day 7 of illness, which is thrombocytopenia, and WBC of 36,300, and albumin was low, 2.7, and ALT was elevated. Echo done in this child initially was normal. On comparing the clinical features with MISC, age criteria is falling between this MISC criteria, which is 0 to 19 years of age, and fever for more than 3 days, with clinical signs of non-purulent conjunctivitis, mucocutaneous inflammation, and the child also had GI symptoms, vomiting, with elevated markers of inflammation was also present, and other microbial causes of inflammation and other tropical infections were ruled out. And the one more criteria that has to be met is any other positive SARS-CoV-2 RT-PCR has to be positive, or serology or positive antigens test, or contact with an individual with a COVID-19. So comparing between MISC and Kawasaki, this child mean age fitted in MISC with fever for more than 24 hours, with having GI symptoms in common, with both having a pro-inflammatory status, thrombocytopenia, and elevated ferritin. So in view of suspected MISC with the Kawasaki phenotype, parents were counseled for IVIG and IV methylprednisolone. Due to logistic reasons, parents wanted discharge and child was referred to the higher center. So course in outside hospital, echo done initially showed pulmonary hypertension, for which child was started on oral sildenafil, and repeat echo done on day 3 of hospitalization showed prominent coronary arteries with reduction in the pulmonary pressures, and NT-proBNP was done, which was elevated in this child. In view of persistent fever spikes, antibiotics were escalated to meropenem along with doxycycline, and in view of persistent inflammation suspected MISC Kawasaki phenotype, IVIG was initiated along with methylprednisolone, and in this child, COVID-19 antibody was positive. So the final diagnosis is multi-system inflammatory syndrome in children with Kawasaki phenotype. The child was treated with IVIG infusion, 2 gram per kg given over 24 hours, along with IV methylprednisolone, 2 mg per kg per day for 5 days. And the child symptomatically improved and was discharged with oral prednisolone for 4 weeks in a tapering dose. And tablet aspirin 75 milligram OD was started and continued for 1 month.
Vignesh, only we are in Zoom meeting. Sir, Chandan sir asked her to attend to Zoom meeting. We are in Zoom meeting, sir. Then we'll see the case. Second, I should see the case.
Inflammatory syndrome in children.
Everyone is in Zoom meeting, no? Your Chengalpattu meter is talking, sir.
Sir, I request the participants to mute. Doctor, you can proceed with your presentation.
Okay, ma'am. Multi-system inflammatory syndrome in children was initially reported in United Kingdom and United States in April 2020 following the surge in COVID-19 infections. This is a hyperinflammatory syndrome with the involvement of multiple organs requiring timely treatment of anti-inflammatory drugs such as steroids and IVIG. It's an uncommon but potentially a serious diagnosis and treatment is assured with good outcomes. The main pathogenesis is in the early infection is a nasopharyngeal colonization or mild infection. Usually the pulmonary infection stage is skipped. With that, there is macrophage activation, T helper and B helper cells. There is cytokine storms which is produced, and there is hyperimmune response which ultimately leads to MISC. So the clinical features can be fever, myalgia, conjunctivitis, rash, lymphadenopathy, oral stomatitis, extremities of swelling of the extremities with erythema, skin peeling can also be present, myocarditis, troponin, pro-BNP elevation, hypotension, hypoperfusion, tachycardia, thrombocytopenia, neutrophilia, lymphopenia. There can also be hyponatremia and renal failure. So clinical types are mainly MISC without shock. Any child who fulfills the WHO criteria for MISC and stable without any features of shock. MISC with shock or multiple organ dysfunction is who fulfills the criteria for MISC and has features of shock or 2 or more organ involvement. And MISC with Kawasaki phenotype is who met complete or incomplete Kawasaki disease criteria as defined by American Heart Association. MISC with refractory disease is who fulfills the WHO criteria for MISC and has not responded to first tier therapy after 48 hours. So line of management is without shock, usually treat with IV methylprednisolone 1 to 2 mg per kg per day. And with shock or multi-organ dysfunction, it's IVIG 2 grams per kg with IV methylprednisolone 2 gram per kg per day, 2 milligram per kg per day. And with Kawasaki phenotype, it's IVIG 2 gram per kg, IV methylprednisolone and aspirin 3 to 5 mg per kg per day. So if symptoms persist more than 48 hours, progression despite the above treatment is considered as refractory disease, and pulsed IV methylprednisolone 10 to 30 mg per kg per day. Intensification of treatment is done along with immunomodulators, that is anakinra, more 4 mg per kg per day. IV supplements is given. Change. Then methylprednisolone can be changed to oral prednisolone or dexamethasone after 3 to 5 days and taper over 25% every week and stop over 3 to 4 weeks with monitoring of inflammatory markers. ECG at admission and repeated 48 hours if cardiac involvement is present, and echo at 1 to 2 weeks and 4 to 6 weeks repeated at 1 year if initial echo was abnormal. Anticoagulants, MISCs with ejection fraction less than 8%, or coronary arteries X4 when it's more than 10, or giant aneurysm the diameter of 8 mm. Enoxaparin, low molecular weight heparin 1 mg per kg is continued till normal coronary arteries are confirmed at 4 weeks after the diagnosis. So, and low dose aspirin 3 to 5 mg per kg per day should be used if platelets are more than 80,000 and continue till normal coronary arteries are confirmed at more than equal to 4 weeks after diagnosis. If patients with aneurysm or risk of thrombosis, it is desirable to continue antiplatelet and anticoagulants as per the risk and need with clinical assessment. Long-term follow-up for complications, mortality is reported in 1 to 2% of affected patients. Higher figures are reported with delayed presentations, like other presentations can be coronary artery aneurysms, cardiac dysfunction, respiratory failure, and renal involvement, and systemic thrombosis can be seen. Thank you.
Thank you, Dr. Purnima, for presenting such a clinically engaging case. It was a very good presentation. Now I invite Dr. Arjun Raj sir to share his valuable comments. Apologies, sir, for reading out your name wrongly instead of Dr. Purnima.
Presentation. Thank you for the nice presentation. So actually, would you like to answer like what was the clinching point for a diagnosis?
So mainly this child presented with thrombocytopenia. So in Kawasaki, there is leukocytosis with thrombocytosis. Even child had other clinical presentation. There was thrombocytopenia in this child. And the COVID antibody also turned out to be positive, which fitted in the MISC criteria.
Right, yeah. So basically, the learning point is usually in MISC there is thrombocytopenia, whereas in your Kawasaki usually you find thrombocytosis. So very uncommon to find thrombocytopenia in Kawasaki. So, and what about lymphopenia? Was it present in this case?
Lymphopenia. But it was not there, sir.
Yeah, so lymphopenia was not there, but yeah, they say that in this usually you see lymphopenia and thrombocytopenia in your CBC. So which is not a common feature with Kawasaki. If there is any other questions from the panel, we'll take it up.
Sir, is there any difference in prognosis, sir, for Missy and Missy with the Kawasaki phenotype, which carries good prognosis?
Mostly Kawasaki, if there is coronary involvement, the prognosis is bad. Similarly, in MISC also, that if there is coronary involvement and if it is not treated properly, the prognosis is bad. Otherwise, if it is caught early and if immunomodulators are started early, the prognosis is really good. So mortality is seen only in around 2% of the entire population have had this.
Thank you, sir. Any other questions? Thank you, sir, for your valuable comments. So now we'll move on to the last presentation. I now invite Dr. Abhirami from Satya Sai Medical College to begin her presentation. Dr. Abhirami, you can share your slides and start presenting.
Good afternoon, everyone. I'm Dr. Abhirami. I'm going to present about SLE, butterfly advanced within. Chief Compliance. Rajva Rajni, 17-year-old female patient from Purvancheri, came to pediatric OPD with the informant being her mother and her relativity was good, with the complaints of fever on and off for past 1 year and complaints of easy fatigability for 1 month and rash over the cheeks for past 2 weeks. History of presenting illness. 70-year-old female patient was found to non-Alzheimer's married couple was apparently normal 1 year back, after which she started having fever, which was on and off for the past 1 year. Fever was insidious in onset and intermittent in nature and associated with chills, but not with virus, and different variations. Paracetamol and antibiotics were given. And each episodes were lasted for 1 week. At present, Chengai is having fever for past 2 days. It was low-grade fever and intermittent. It was more at night. Fever was ranging on medication, and the child was active in the interfebrile period. History of chills was present. History of loss of weight and loss of appetite was present, and history of 10 kg weight loss for last 1 year is same. History of easy fatigability for 1 month. And the tiredness was started with exertion initially and gradually leading to fatigability with daily activities. And it was associated with bilateral lower limb pain, depending on muscles and medication. History of nausea after food intake was there for 1 month, and history of rash over bilateral cheeks and nasal bit for 2 weeks. And history of oral ulcer was present, and history of difficulty in swallowing for past 2 weeks, and history of alcohol is also present. No history of early morning stiffness and joint stiffness. No history of facial puffiness, period edema, decreased urine output, hematuria and frothy urine, and no history of headache and blurry vision. It rules out lupus nephritis, and no history of chest pain, palpitation, breathlessness, orthopnea, and cough or hematoxis, and no history of giddiness, confusion, disorientation, loss of consciousness and seizure and symptom. No history of weakness of one side of the body and deviation of mouth, numbness or decreased sensation. Use of CNS process. And no history of abnormal behavior changes and use of neuropsychiatric abnormalities. No history of easy bruising and recurrent transfusions. No history of abdominal pain, jaundice, vomiting and diarrhea. No history of discolorations of finger on cold exposure. No history of chronic cough, recurrent infections or allergy. No history of body administration, increased frequency and urgency. No history of mental psychiatric. Past history of your periods and hospitalization for similar than 2 weeks back, and I was explained a bit the time which was taken for 3 days. Patient was taking taxane and paracetamol and iron tablets on and off for the past 1 year. And history of fever with bilateral leg swelling was present 2 weeks back. At present, it was not there. History of entry fever 1 year back and documentation was also not available. History of deworming 1 month back and no history of TB contact, bronchial asthma and seizure. Moving on to antenatal history, spontaneous pregnancy and antenatal period was uneventful, and natal history 1 year normal vaginal delivery, flight immediately afterwards, and breastfeeding was started within 1 hour after birth. Postnatal history, postnatal period was uneventful and discharged within 5 days, and exclusive breastfeeding for 6 months was given. Immunization history, immunized up to date, last vaccine was 15 years, at 15 years of age. Developmental history, currently studying balanced standard, scholastic performance, no developmental delay. Menstrual history, attained menarche at 13 years of age, regular cycles, 3/30, and no passage of clots. Family history, firstborn child of non-consanguineous marriage, paternal grandfather, history of carcinoma is there, and he is died due to carcinoma of bladder and prostate. Maternal grandmother has history of type 2 diabetes mellitus, and mother has history of hypothyroidism 8 years back and was on levothyroxine 75 mg. Younger sisters 10 standard, no similar complaints, no other complaints proven. No history of TB contact and no history of bronchial asthma. This is the pedigree chart. Socioeconomic status. According to modified Kukusami scale, they belong to lower middle class. Nutritional history calculated using 24 hours Nekal method. The expected nutritional requirement for her is 2240 kilocalories, and she's taking 1250 kilocalories, which was deficit is 990 kilocalories per day, and the protein requirement is 57 grams per day, and the deficit is totally she is taking 35 grams per day, and the deficit is 22 grams per day. Summary: Varshalakshmi, a 17-year-old female from Guruvagiri, first born out of non-consanguineous marriage, presented with intermittent low-grade fever for the past 1 year, associated with chills, predominantly at night with loss of appetite and significant weight loss of 10 kg over 1 year. She also had easy irritability and nausea for the past 1 month. She developed a rash over bilateral cheeks for the past 2 weeks, and history of dysphagia and bilateral lower limb pain was present. Her developmental milestones were appropriate for age, good scholastic performance, and vaccinated up to age as per national immunization schedule. With this history, I would like to answer that the child is suffering from multi-systemic disease, most probably of autoimmune etiology or infective etiology, and I would like to proceed with the examination. General examination: patient is conscious, oriented to time, place, and person, and able belt. Pallor was present, and cervical lymphadenopathy was there, and the lymph node lymph node was palpable in the right upper cervical region, approximately 1 into 1 centimeter, which is round in shape with smooth surface, well-defined border. The overlying skin is normal, not tender, not major, not fixed to the skin. So no interest, cyanosis, jumping, and edema. Vitals were stable. Her heart rate was 126 beats per minute. BP is 100 per 70, measured at rest, upper arm in sitting position. Respiratory rate is 18 beats per minute. Temperature is 97. SpO2 is 99 atmosphere. We noted tachycardia while she was here. The periphery is perfusion is good, hydration is good, and CRP is less than 3 seconds. JVP was normal, 3 centimeters. This is the anthropometry of the child. Height, observed height is 163 centimeters. Expected is 162 centimeters, which is falling on 70 to 98 percentile. Normal height for age. Weight is 41.5 kg. Expected is 57 kg, and falls under 10 to 25 percentile, which is under nutrition, low weight for age. The BMI is 15.5, and it falls under 3rd to 5th percentile. Interpretation is thinness and underweight or underweight. Moving on to head to toe examination. Shape of the head is normal and face macular rash over the bilateral cheek and nasal bridge, sparing the nasolabial fold. Eyes, no cataract, no white spot. Ear, black rash noted over the concha and behind the pinna. No congenital abnormality and spinal deformity was seen. In throat, oral ulcers were present and compressions were present till posterior pharyngeal wall and mild nodular enlargement were present, which is grade 1. Normal chest and abdomen was normal, and upper and lower extremities lashed over the elbow were present and over the bilateral lower limbs were present. Spine is normal. These are the pictures. Here we can see the oral ulcers and the lash over the ear and behind the pinna. Here we can see the lash over the elbow and the lips is not clear. Systemic examination, serious examination, and inspection. Shape of the chest wall appears to be normal and chest wall appears to be symmetrical. No pericardial bulge, no enlarged veins over the chest wall. Trachea appears to be in the midline. Apical impulse not visible. No visible pulsation at aortic area, pulmonary, epigastric, suprasternal, carotid areas, and the back. No enlarged neck veins. Moving on to palpation. Tracheal position confirmed by palpation to be in the midline. Apical impulse palpated in the fifth intercostal space, just 1 centimeter near to the mid-clavicular line, and it is normal in character. No other palpable marker, no parasternal heat present, and no dilated vein seen. And auscultation done over the mitral, tricuspid, aortic, pulmonary area, and first and second heart sounds and no marker present. Other systems, respiratory system, bilateral RLG was present, normal vesicular bell sounds were present, no adult sound. CNS, no total neurological deficit, tone and pressure normal. Abdomen examination saw non-tender, no organomegaly. Summary, Varsha Lakshmi, a 17-year-old female from Guruvanjali, born out of non-consanguineous marriage, present with intermittent low-grade fever for past 1 year, associated with chills, and predominantly at night. Loss of appetite over the past 1 year, and she also had fatigue and nausea for the past 1 month. She developed erythematous macular rash over the bilateral cheek and nasal bridge and scarring the nasolabial fold for the past 2 weeks. History of non-scarring alopecia, dysplasia, diffuse myalgia involving bilateral lower lip was present. Her developmental milestones were appropriate for age, good scholastic performance, and vaccinated up to age as per national immunization schedule. On examination, the child was noted to have pallor and cervical lymphadenopathy. In addition, a visible rash was present was noted behind the ear, along with the cutaneous rash over the extensor aspects of the elbow and over bilateral limbs. Diagnosis: the overall clinical picture is suggestive of systemic lupus erythematosus. These are the investigations we have done on the day of admission. HB was low, and peripheral smear shows moderate normocytic normochromic anemia. Urine protein was normal, and RFT was normal. Serum electrolytes were within normal limits. Thyroid profile, it is normal, within normal limits. LFT is within normal limits. ECG showed sinus tachycardia, and corrected QVC was 450 microseconds, and 2D echo showed structurally normal heart with a good biventricular function. We have done manual tests to rule out TB, and chest X-ray were done. There is increased bronchoalveolar markings were present, and we have done Coombs test. Direct Coombs test and indirect Coombs tests were negative. Smear for NPMR is also negative. Viral test is negative. Throat swab showed resistant qualities negative staphylococcus. USD abdomen was nil significant. Impression was nil significant. CRP was elevated, positive 12, it was there. ESR 55 mm per hour, it is also positive. ASO title is negative. CKMB is within normal limits. Troponin I is negative. CPK was within normal limits. Uric acid is also within normal limits, and serologies are non-reactive. These are the SME profile we have done. It shows that AMA anti-nuclear antibody, very strong positive, grade 4 plus and homogeneous pattern. Titer is around 1:3200, significantly positive. High.
ఇవన్నీ కూడా చేయించారా
DNA
బయట
antibody positive. Anti-cardiolipin antibody IgG and IgM is also positive. And beta-glycoprotein 1 IgM, it is also markedly elevated. Q antibody that is positive. And RNP and SNP antibody is positive. Nucleosome antibody is also positive. Histone antibody is positive. Ribosomal P protein antibody is strongly positive. EMS elevated and AMA M2 antibody and DS70 antibody is borderline. And lupus antibody is anti-phospholipid antibody IgG and IgM. And beta-2-glycoprotein IgG is all negative. Interferon gamma release assay is negative. MA2 antibody, SM antibody, SSA antibody is negative. Rho52 SSB and SCL70 antibody is also negative. PM SCL100 antibody, Jo1 antibody is also negative. Finally, we have sent for CD9 for the Unicom TB. It came out to be positive with the NDT resistance was not detected. So this treatment we have started the patient on paracetamol, pantoprazole, and ceftriaxone for 3 days. Then we stopped and then gave NSAID and prednisone. We started on low dose 0.5 mg per kg per day and ranitidine. On one patient, the rashes were like this. You can see the rash and oral ulcers and discoid rash. On day 3 of admission, this is 2 weeks post treatment with steroid. The rashes have been reduced. This is the income criteria for diagnosing SLE. Here we have entry criteria ANA titer is positive, and we also have a score of 18 from this. So it is a positive case of SLE.
Thank you, Dr. Abirami, for the elaborate presentation. Now I invite Dr. Suresh to share his valuable comments.
This case basically 17 years old adolescent child. So we wanted to present this case to highlight the classical presenting features of SLE. And also in this case, we have a coexistence possibility of TB also in this child. So the child is now on HCG hydroxychloroquine along with steroids, and AED treatment is also ongoing. We are planning to do for duration of 9 months. Any questions other than that?
Any questions from the audience?
Yes, all right. So, how that X-ray is all right. How did you get tuberculosis? No, no, but where's the lesion? The X-ray test was all right.
The X-ray lesions were not there, but Tronan came to be positive. The manual test also was negative.
Yeah, but I mean, there's no explanation now because the X-ray test is clear. Where did the tuberculosis come from? You have to have some lung lesion to bring out the tuberculosis.
That was a well presented case, has well worked up also. Thank you for joining. Is there any other doubts, sir? Or any questions?
Okay. Madam, can we wind up the session, ma'am? Any further questions? Okay. So I would like to congratulate all the presenters for their excellent preparation and presentation. And I extend my sincere thanks to all the moderators for their guidance and valuable insights. And on behalf of IAP Chengalpattu, I thank all the participants. Thank you.
Yeah. Screen share.